Okay, good afternoon and welcome to the Oxford Martin School, and welcome to the first seminar of this term's series on technology for tomorrow. Today's talk is the impact of new technologies on healthcare research by Professor Martin Landray. Now, Martin is Professor of Medicine and Epidemiology within the Nuffield Department of Population Health. He's also Deputy Director of the Big Data Institute within the Shing Center for Health Information and Discovery. His work seeks to further understanding of the determinants of common life-threatening and disabling diseases through the design, conduct, and analysis of efficient, large-scale epidemiological studies, including clinical trials. He's going to talk today, as I said, on the impact of new technologies on healthcare research, but in particular, his focus will be on the use of technology to increase the scale and reach of clinical research studies. Now, Martin will talk for about 40-45 minutes, and then there's going to be plenty of time for questions and answers afterwards. So, well, over to Martin. Thank you.
Well, thank you very much. Thank you for a wonderful invitation. It's a great privilege to be here. As was introduced, I'm going to take a particular angle on technology. I'm going to take a particular angle on healthcare research. In particular, it's the scale of research and the scale of the new opportunities that I want to emphasize. So much of what I'm going to talk about is about big data. I've taken liberty with the title technology, but it strikes me that if you have technology and you don't have analysis, then you don't really have technology that's usable. And that the focus of the technology and the analysis needs to be on the healthcare research. So if I am going to be Deputy Director of a Big Data Institute, I probably ought to know what big data is. And it's a term I'm going to use relatively frequently. I think it is whatever you want it to mean. But a common definition would be data that is large in volume, wide in variety, perhaps high in velocity. It's coming in at a fast rate. Of dubious veracity, it's not all accurate, and of questionable value. There's certainly value there, but there's also an awful lot of noise. And if you want a picture to show you what big data is, it probably looks like something like this. Now, this is a map of Facebook connections from about 2010, 2012. You can see that there are one or two gaps in the world, for example, China, where in fact they don't use Facebook but use an alternative. But you can see just how connected that world is. You can see that there are large amounts of data flying past our ears all the time, and yet there is sense coming from that. Those messages are sent with particular purposes in mind. This plot was put together, this picture was put together to show something quite different. It shows a geographical representation. So now we have a map of the world, albeit a bit patchy in places, which has come from data which have been collected and put in place by run-of-the-mill activities for completely different purposes, and not even was everybody's purpose the same. It was broadly speaking to communicate, but about different things to different people. So medical research is going through something of a revolution. I'm sure every generation thinks that, but I think it is true at the moment. And that is that large population-scale data sets have been made available through innovations in high-throughput technology. So if we think of genome sequencing, it's now possible to sequence the entire genome for about $1,000 in less than a day. You compare that with how long it took to sequence the very first human genome in the Human Genome Project only 10 or 15 years ago. There are vast swathes of data coming through clinical and health service activity, enormous quantities of data coming from imaging, whether that's imaging of individual molecules all the way through to imaging of the whole body. And then there's vast quantities of information coming from mobile technologies, from sensors, and from the internet. So we have no shortage of data. And if you want to sort of think about an alternative way of looking at or thinking about big data, these data sets are large, high-dimensional. They're not all measuring the same one or two things. They're semi-structured at best and highly heterogeneous. So if I give you the data, you're not going to be able to plot it on the back of an envelope. You're not going to be able to put it into an Excel spreadsheet. It's difficult to summarize and to see. It's been collected in many different ways for different purposes, stored in all sorts of different ways, and in fact it can't be, when you pull it all together, stored in a standard database structure. And it may in fact be in many different places, and you may need to analyze across different physical locations as well as virtual locations. And that requires new statistical and computational methods to make sense. But I've just shown you a map that makes sense of data that is out there in the wild. So if we take big data for health research, that's my perspective, I think it offers us 4 broad things. The first is simply scale. We can now collect information on unprecedented numbers of people. Now, in medical research, typically what we want to do is find people with something of interest, whether it's a disease of interest, it's a habit of interest, it's an outcome of interest, and we by and large call those cases. And by and large, we then want to compare them with some form of controls. It might be people who never go on to get the disease, or it might be people who haven't got the disease now, or it might be people who are not on a treatment or don't smoke, or whatever it might be. But we want large numbers of people, because with size comes the precision. The second is the breadth. We can now study an enormous range of exposures. In other words, things that we do, things that we're exposed to, and indeed genetic variants too. We don't just confined to addressing one question, and likewise for outcomes. So patients who have had a myocardial infarction, classically one would go on and test, are they likely to have another myocardial infarction or heart attack? Are they likely to have a stroke, and are they likely to die? But there's an awful lot else that might happen to those people, which might be really quite informative, like what happens to their cognitive health, are they more at risk of dementia, what happens to muscle symptoms, what happens to their activity, all these other things. And then I think one of the critical elements is length. It's all about time. Typically, most of the studies that probably we all do are snapshots in time. Here's a bunch of people we're comparing with another bunch of people as they appear now. Now, just at the moment, nobody in this room appears, at least to this cardiologist, to be having a heart attack. That's not, sadly, the same to say that none of you have had a heart attack and that you're all at the same risk of having a heart attack in the future. Taking in that time dimension and trying to understand what the projection is of those who may or may not develop heart attacks, or let's take cognitive function. Let's think about how our cognitive function works when we're 20, when we're 40, when we're 60, when we're 80, and let's hope when we're 100. You can imagine that there's gradual declines, and not all our declines are the same. They're not even the same profile. Some might be stepped, some might be gradual, different things happen. Understanding what drives that, and what influences that, and what we can do about it is something that we can get from these sorts of data. And finally, depth, the level of detail that we can get. So we can now take MRI scans of the brain or the heart and understand really at essentially microscopic or smaller detail, not only the anatomical connections, but the physiological connections, the pathways that connect things together in detail. And the big data piece is when you try to do all this at the same time in large numbers. So I think it really does give us the power to understand disease, develop treatments, and improve healthcare. But there are challenges, and you can imagine there is an awful lot of noise in what's going on here, and there's a huge potential to draw the wrong conclusions. So I'm going to use as some examples a research project which has been going on, and it's largely led from Oxford, although it's a national project and the data are open access to all. This is the UK Biobank study, which I've been involved in since its start over a decade ago, where we took 500,000 middle-aged Brits and we recruited them to come to a dedicated study. These are people who may or may not have anything wrong with them. Actually, what we did was we found 9 million names and addresses of people who had a GP in the UK and invited them. That's the selection. And 500,000 turned up in 3.5 years. Now, 500,000 is quite a lot of people if you want to assess them in detail. And this was where the technology started to help us to do that sort of scale of research. So this is electronic consent. It looks pretty crude now, because now if you want to check into an airport, you want to buy a train ticket, all those things, a touchscreen computer is just there. In 2005, we were 2 years or 3 years before the advent of the first iPhone. But the principle is about how to use the technology, capturing the information, explaining what is in this study, capturing information about are you happy to take part of it in a way that has the right ethical governance, it has the right legal governance, so that actually this is a valid form of consent. We managed to do that in 500,000 people. We were able to, again, study things in scale. This is a research environment, it's albeit a big one, and we used it as, if you like, a sort of industrial approach. So we had suites of rooms. One of them was on the top of the Westgate shopping centre in the middle of Oxford, where we would put in banks of touchscreen computers, which people answered their own questionnaires. There was no transcription of the results, no room for errors in how the data were coded. We were then able to collect lots of additional information, whether it's from exercise information and ECG. Down in the left-hand corner, it was about spirometry and breathing function, or in the right-hand corner, detailed assessments of the eyes. Over 1,000 data items in less than 2 hours, and 100 participants per clinic per day, 600 in total, scale up 500,000 over 3.5 years. That's not possible without the technology. The technology is now all old. It's actually, in technology terms, very old, but it demonstrates the point that we are actually able to do studies at a scale and a depth and a breadth that we weren't able to before. So these are the sorts of numbers. I've shown you images of some of the sort of things that we've tried to collect. We have 500,000 people in the study. We've done cognitive function tests on 140,000, collected diet information multiple times on 200,000, done 100,000 ECGs, 60,000 retinal scans, 100,000 activity monitors. I'm going to go back over some of these as I go through. We can now see that we're actually getting really quite a global picture of an individual's health profile, if you like, but what's really important, of a very large cohort of people, in which now different research questions can begin to be asked. This requires innovation, it requires technology, it requires efficiency, but it also requires close connection between the technology experts and the clinical experts and the research experts to make sure that the data that are collected are going to be useful. So this is quite a sort of protocol environment. So that was my example. I'll come back to a few use cases from that a bit later on. I want to emphasize this business about numbers. Large numbers gives precision, quite often even with quite crude data. So this is the relationship between ischemic heart disease, that's heart attacks, and systolic blood pressure, that's blood pressure. In 5,000 people, as you can see, the higher the risk, the higher up the y-axis, and blood pressure, the higher the blood pressure, the further right they are. The question I'm asking is not, is high blood pressure bad for you? Because we all know that. But the question is it similarly bad in my age group and my mother's age group? Now, so I've plotted this all out, or one of my colleagues has plotted this all out, and looked at decades of different people, and frankly, it's all a bit of a mess. That's 5,000 people. That's about the amount of data that most clinical algorithms in cardiovascular medicine are currently based on. That's what happens if you were to study 50,000 people. It's beginning to become somewhat clearer. And if I study 500,000 people, suddenly you get clarity where there was none, and you get engineering-grade diagrams which are giving you the precise relationships between blood pressure and heart disease risk at different decades of age. All I have done from the left to the right, or all my colleagues have done from the left to the right, is to add numbers. It's still simply a death certificate code of died from heart disease. It's still a clinic measurement of blood pressure. No clever technology in either of those, no additional precision, just adding the numbers is giving us that precision. So studying things in large numbers matters. So if we're going to do that, let's start with the data that we've already got, the data that are out there in the real world, routine data. So again, back to Biobank, and we're, I guess, 3/4 of the way through this process, but actually linking in those 500,000 people in Biobank to all the data that's actually already out there and known about those people. This is all with consent. About whether, obviously, eventually whether they die, whether they get cancer, whether they go into hospital, but also there's an awful lot of information on what environmental exposures they have, what the air quality is like and so on, what drugs they get, issues about the primary, from primary care and the built environment. If you can bring that information together for different questions, it will give different insights. And the question people come up with is, again, this is all routine data. It's coded often quite crudely, often by people who don't have any view about it's going to be used for research purposes. It's a practical coding system. So is it valuable? So this is data from Michael Goldacre, who's in the same department. For 50 years in Oxfordshire and the surrounding region, about 3 or 4 million people, in fact, every person who's gone into a hospital, as they come out of the hospital, their reasons for being in the hospital are recorded. So this is the information for typically young adults who are recorded as having gone into hospital with mumps. Now, mumps is largely a primary care. It's largely a GP and small child disease. So if you get into hospital, you're sick. So this is just the tip of the iceberg. What you can see in that red line as it spikes is every 2 years there's an outbreak and then it goes away. Every 2 years there's an outbreak and then it goes away. It's a very classical picture. It's in all the textbooks of what happens with these sorts of infectious diseases. Then something happens in about 1987, as I go to medical school. It's not to do with me going to medical school. Something happens in about 1987, and this epidemic, this cycling disappears. What happens is, of course, that immunization is introduced. And so the cases, after taking a little while to generate herd immunity, disappear to nothing. And then in 2003, 2005, you can see this spike return again. Why does it return? Well, because a few years earlier, in about 95, 96, there was a scandal about the triple vaccine, which the mumps vaccine had now been mixed in with. There was a very strong media interest in that, and the vaccination rates dropped from something like 95% to something like 75%. Herd immunity went away, and these spikes occur. So this is just crude data of why do people go in hospital, giving us a really good picture of what's determining health. So that's one use. Here's a second use. This is about a disease called Marfan's disease. It's one of about 2 conditions that is extraordinarily common in basketball players, because these people are typically 6'6", 6'8" in height. I can't do that in metric, it's tall. It's a genetic condition, and among other things, what they get is you can imagine, it's a very long and distorted aorta, the main artery. And over time, there's an increased risk that the lining of that artery splits off, and they end up having a heart attack. This is called an aortic dissection. It's as if someone had put a knife down and peeled off the inner layer, and then they end up with major medical complications and also death. It doesn't happen in many other conditions. It does happen, but not much. But the relative risk in the people who've got Marfan's versus not is about 150-fold. How do we know that? Because we took a cohort of 10,000 people who got Marfan's disease from the national data sets, and we were able to say, of those who've got Marfan's, how many then go and get these diseases? It's not a surprise. 150 with that sort of level of precision is quite useful to know, and numerically it sort of quantifies it a bit better, but it's not a surprise. What is a surprise, at least to that area of the research and clinical community, is that these same patients also get what AAA, abdominal aortic aneurysm, so right down here, so if you like behind the belly button, which is a completely different disease, or was thought to be. It's a disease of 60, 70-year-old smokers, not of youngish people with Marfan's disease. 8-fold increased risk, and likewise of stroke, a 4-fold risk of stroke. So this is opening up now new clinical questions, new research questions that now need to go and be tested with genetics, with more detailed imaging, with other studies. All based simply on standard hospital-coded, scruffy data. And if we turn to genetics, there's a lot of information about genotype, so what the genes look like, and phenotype, if you like, what the patient looks like, or what the clinical condition looks like. And a classic way of looking at this is a so-called genome-wide association study. So across the bottom are the different chromosomes. That's what's shaded. Each one of these is a little point at which somebody said, what's the genetic piece variant at those points. The further up the graph, the more likely they are to be associated with, in this instance, diabetic retinopathy. And handily pointed out for us in one place, GWAS significance SNP, as it's called, is a gene or a variant which is associated with diabetic retinopathy. So-called Manhattan plot, nice little spikes at the most extreme places. So that's put the genome along the bottom and said, okay, so if you've got this variant, so if you've got diabetic retinopathy, what variant's predicted? Here we got an answer. You can flip that round if you've got enough data and say, let's put the disease across the bottom. This is a standard dictionary, if you like, of, or index almost, of types of disease, going from, I think it's cancer at the beginning to probably trauma at the end, I can't remember. But essentially, different diseases, and then saying, okay, we've got a particular SNP that we're interested in, which diseases did it associate with. What's really interesting about that is you from time to time find two diseases that you thought were completely unrelated actually share some genetic information. So this begins to change the way that we think about code classify disease, driven by the numbers, driven by scale. So one place that we can use all this technology, and I'm sort of gradually building towards what might look like more advanced or sexy technology, but it comes because you have to take it from the starting principles, is around streamlined clinical trials. So I've spent a lot of my career running very large randomized clinical trials. Something between 10 and 30,000 people would be a typical trial. Now, why do I do it? Because as a clinician, it's the information from randomized clinical trials that actually tell me what to do. They actually tell me which drugs work, which drugs don't work, and what the side effects are. And there's a good argument that the many clinical decisions that are made in the absence of clinical trial evidence actually may well be harmful to patients and public health. Put this in picture, probably the best evidence base for any aspect of clinical medicine comes from cardiology, in terms of the number of trials we have. If you look at the international recommendations about how different patients with heart disease should be treated, it's probably about 15% of all the recommendations are supported by clinical trial evidence. The other 85% are not, and that's the best. Trust me, I'm a doctor. Now, one of the challenges is that these trials cost enormous amounts of money. Now, on the left is, and these data are 10 years old or so, perhaps not quite that long, but certainly at least 5 years old, is the typical costs for a late phase study, for a 20,000 person study, to demonstrate that a treatment is effective in, say, cardiology. And it might cost close to $500 million. That's 20,000 patients for 4 years follow-up, collecting the information, submitting it to regulators and all that sort of stuff. Now, it's possible to streamline that, and in fact we do, down to $150 million or even down to, and this is really where a lot of my work comes in, trying to streamline it down even lower. And the question is, what difference is there between the left-hand picture and the right-hand picture? And the answer typically is excess. People want to do more and more and more, when in fact, actually, if you just did less and did it on bigger numbers, you get much better, more reliable answers. But can technology help us with some of this? Well, again, I want to go back to the routine clinical data, because it's about where are the errors and do they matter. And I'm going to start off with a study called the Heart Protection Study, which is actually the reason I moved to Oxford in the first place 15 years ago. This was a study of simvastatin, which is now widely used statin, versus placebo in people who had had heart attacks and other sorts of vascular events. And down the left-hand side are different sorts of vascular event that people might have, starting with heart attacks and then strokes, and then coronary stenting and those sorts of procedures. Everything to the left of the line, of the solid line, is benefit. And what you can see overall is that there is a significant benefit of taking a statin versus not. And this is the risk ratio, so if you want to turn it round, that's a risk reduction of 24%. Now this was based on 4,500 events in 20,000 people. To get this information, we not only did the trial, we then collected information on every report that the patient gave the nurses about whether it was a possible heart attack, a possible stroke, and so on. 30,000 events. And a colleague and I sat in an office. We were brought to Oxford to sit in offices for an entire year and trawl our way through these 30,000 events and say, yes, I think this is a real one, or no, I don't. And this beautiful result emerged. Now, if I'd never come to Oxford, I'd have got this result. This is directly, as reported, simply the nurse saying to the patient, have you had a heart attack since I last saw you? Nobody does any checking after that. you can see that actually just looking at the pictures, frankly, nothing has changed. It's all in line. You can see that there's a significant reduction in the overall endpoint, and now we've got a hazard ratio of 0.77, not 0.76. So we've got a reduction of 23%, not 24%. Both are statistically highly significant. I think the Z-score, if you want that, changes by 1/100th of a point. Both are clinically significant. Actually, both are financially significant in that this drug was licensed around the world and is used in widespread clinical practice. So if we had not adjudicated at all, actually even quite crude data, but on these numbers, and in this case, in the context of a randomized trial, just does the job fine. So can we do even better than that? Well, we used, this is the same result plotted slightly differently. This is the group on placebo and their risk of having one of those nasty events. You can see by the end of 5 years, about 25 or 30% had. This is the placebo group. You can see by 5 years, about 20 to 25% had. So that was the study. At that time, it cost £21 million. It probably would cost double that in today's money, given that this was 20 years ago or so when this was started. We then did additional follow-up, and all we did for the additional follow-up was to collect data on deaths and cancers from national registries and send the patients I think it was 6 or 7 item questionnaire. Have anything bad happened to you since we last saw you? And you can see that you can get extended follow-up. You can continue to see the benefits. Actually, what I'm not showing on here is you can also show that there isn't any risk of long-term safety issues like cancer, because the lines overlap all the way out to now 10 or 11 years. And this additional follow-up costs just £200,000. And it could, I think, be even cheaper if we'd had more technology available to us at the time. And other people in this example that comes from the States have looked at, again, this issue about if you do this full adjudication and this really detailed review, the 30,000 case notes that my colleague and I trawled through, or you just say, let's go to the routine data, in this case, the medical system data in these centers in the US. You know, what do you lose, what do you gain? And the answer is, all you need to know is that whether you use the fully adjudicated, intensively examined information, or simply say, what's in the routine healthcare records, can you send it to me electronically? You get identical answers, each of which says, in principle, that hormone replacement therapy in women is actually not terribly good, either for heart attacks of any particular type. And you get the same answer either way. It's efficiency. And so now people are taking that one stage further and saying, well, actually, you know what? Every time we do procedures, I told you that 15% of what we do in cardiology is evidence-based, and the other 85%, well, isn't. Can we actually, when we're now doing procedures, so in this case, people are in the cath lab, they're doing a stent, should they do something extra and suck out a bit of blood clot at the same time? Sounds like a sort of trivial question, but it's actually quite an important question. What they can do is actually say, well, rather than make it up, and there's this one, you know, one surgeon likes to do it, but another surgeon doesn't. Today's Tuesday, so we'll do it. Tomorrow's Wednesday, so we won't. We've got a bit more time, a bit less. Yeah, or this person's older or younger. Why not just randomize? So within the context of routine clinical practice, people are now beginning to be able to randomize and say, actually, I don't know for certain which way to go, and therefore we can randomize. And we can get actually very cheap trials in the context of these registries. In this case, it turned out that sucking out the clot or not sucking out the clot in 7,000 people made no difference. It's a very efficient way of answering these clinical questions. So with that sort of preamble and some use cases in mind, I'm going to actually talk about the topic in hand, which is technology, and give you some examples from web, smartphones, and sensors in particular contexts. So my first context is around exercise and activity. And the reason I've chosen this is, well, first of all, actually there's very little true evidence about what level of exercise, what type of exercise or activity is relevant for different health outcomes, and so on. And you need scale, and you need to do it largely in the community. You can't bring people in and say, I want you to run on this treadmill. I mean, that gives you some information, but you really want to know what's going on across Oxford just now. And if we were able to improve the bus routes, give people tailored advice, whatever it might be, would they do more exercise or less exercise? And in fact, what would be the health consequences? Would they be more likely to fall over on the ice and break their wrist, or whether in fact it reduced their risk of heart attacks in the long term. The answer is probably both of those things, but you need some numbers on that, and it won't be the same for everybody. So back to Biobank, this 500,000 people. What we chose to do was put in an academic grade sensor, an accelerometer. It's the same thing that's in your same sensor that's in all your mobile phones. It's just without all the front end flashy bit, which actually is not terribly reliable, but you probably know that. And to record data on activity over a 7-day period in 100,000 people. Now, the challenge is not the technology. That thing on the wrist is the same as the thing on many of your wrists, in your pockets. It's been around a long time. The challenge is, how do you know what to make of that? What is being active and what isn't? So here's a single recording. There are 3 lines, because there are 3 dimensions, up, forwards, and sideways. One of the lines is always offset, because there's always gravity. And it turns out there's quite a significant issue about what you do about gravity. And if you look at this single tracing for one person, which has been carefully annotated with what they actually did, because it was one of the staff who did it, they were asleep here, they jogged to work, they worked during the day, they jogged home, an enthusiast, this person, they sort of wandered around in the evening, did the washing up, and went to bed and fell asleep. Alternatively, in this particular person, who presumably we think probably went to sleep, the line then goes flat. In other words, they took it off, put it on the bedside table, or whatever else. So if I show you those recordings, you can begin to tell a story. And if I show you these recordings and the context, you can say, ah, yes, I know. It's obvious. So this is wearing around the office. This is presumably making coffee. This is swimming. And this is squash. If it continued a bit longer, we'd have worked out whether he'd won or lost the point, I guess. So from those, you can begin to see the types of activity. Not hard. But when I show you that one that I had earlier, the trace at the very top there, and now I give you 100,000 of those and say, is this person very active or not very active? What sort of activity are they doing it? How long for? What intensity? And so on. It's a much harder challenge. And this is where the technology and particularly the analytics comes in. So for Biobank, we took 4,000 devices. We cycled them round, so we managed to get 100,000 recordings each week. This is an organizational feat apart from anything else. The data collected, well, one of those devices takes 8.6 million readings per day. We had 7 days per person, 100,000 people, which is this big number here, number of readings. If you use standard analytical tools, the time to analyze that is about 12.5 days. You can drop it right down to about 40 minutes using more sophisticated analytics. Don't ask me the details. That's why I employ people who are computer scientists and engineers, even within medical sciences. And this is the sort of information you get. I mean, these are very early figures, and you could say, well, this isn't rocket science. It isn't rocket science, you're right. But the first question you want to ask is, will people wear these things? And will they continue to wear them when they're explained in this, albeit slightly artificial setting, of 100,000 people who were selected from 500,000 people who already selected themselves to take part in research? And the answer is that the average wear time was 6.8 days out of a maximum of 7. It didn't matter whether they were middle-aged, that was the youngest group we had, or old age. The wear times were pretty similar, and pretty similar in men and women. So we're getting good quality information. Well, the second thing you can ask is simple questions, just to make sure that there's a sanity check. What happens to activity among the older versus the younger? And you can see that the activity, it doesn't really matter what this is, further up the scale is more activity, that the younger people do more activity than the older people, and that's not surprising either. You can also see that it starts off very similar in men and women, and in fact tails off more in the men than it does in the women. You can speculate about why. But then you can actually ask new questions that you probably couldn't get the answer to any other way. This is more complicated, but what it's saying across now activity on the y-axis, hour of day across the x-axis. So you can see that each of these lines is a different age group. And you can see that by and large, in the morning, when everybody gets up, they all do pretty similar amounts of exercise. There's some difference, but not substantial. Once it gets to lunchtime and thereafter, those who are 75 to 79, that's where their activity declines, whereas the younger age groups continue. Now, I'm not addressing the question of why or what can you do about it, or is it a bad thing, but just illustrating that now we can get insights that we wouldn't easily be able to get any other way, and on 100,000 people. And so if we move forward from there again, and I can see colleagues in the room who've worked with me on this one too, and think about, actually, well, that was in a research setting. It was using a research-grade device and getting information on 100,000 people. What would happen if we converted all your iPhones or your Google phones or your Androids or your whatever it is that is your gizmo of choice, and we actually use those with your consent to try and track how much activity your people are doing? And then we can start to address questions like, if it's icy, do people do less exercise? What are the risks, and so on and so forth? And so we've been working with Stanford and with the engineers here in Oxford on both an Apple version and an Android version. And what's interesting is that people are really willing to do this. When this was launched, actually from Stanford in the US, 10,000 people consented to use this in the first week, 30,000 after a month, and 50,000 after 3 months, for no cost to us. Large amounts of data collected. We can address all those sort of governance and ethics questions, or the personal questions that really matter in human health research. So in this instance, explaining to people screen by screen what the potential benefits of the research are, what the research involves, do they understand this, do they need more information, all of those sorts of aspects. And you can imagine, jumping ahead of myself a bit, that one could use very similar technologies in standard healthcare settings, so in GP surgeries, in my waiting room at the hospital, for people who are coming in who might or might not be interested, actually, frankly, whether it's in research or their clinical care or what might happen to them or their relative, starting to use these sorts of technologies to actually explain messages much more clearly than those really rather hideous, I don't know if you've seen them, research consent forms, which in the UK are typically about 4 to 8 pages. In the US are something in excess of 20 pages of very small writing written by lawyers. Actually, this can start to explain to people what the real deal is and get much better engagement. And then take consent. And you can extend this, and I'll just flick through these really. You can ask questionnaires about people's health, how much pain they feel, how healthy they feel, is today a good day, all those other things which you might want to know for whatever your research question is, and people will do this stuff. You can also track the amount of activity, because there are accelerometers in those phones. You can collect activity data, but also because there's a huge amount of navigational software in there, whether it's using the GPS signal or the wireless signal or all those other devices. Now, of course, there are privacy issues, but that's why building the consent into the whole thing, and building the consent in not just a way that it's like the software license agreements that you all tick without reading every time you need an upgrade to Windows or to Adobe PDF Reader or whatever else it might be, but actually consent that is truly engaging, truly informative. And you can also use it for education, so you can actually feed back. And now we can start to loop in the randomization on top of that. So maybe there are different things that we should be educating different sorts of people about. Maybe we don't know which is best, but maybe we could actually randomize. We could show some people one form of educational material and others a different form. Now, if you think that that's strange, that's how Google works. Google does hundreds of thousands of randomization tests. The engineers call them A/B tests. Every day, you click on a website, a search site, it has a pink banner. Somebody else clicks on it, it has a blue banner. You do that 100,000 times, it transpires that pink banner is the thing that people will go for. Pink banner continues. And you can do all of those randomizations over and over again. It's the same principle, only we're doing it with consent and knowledge. Google are doing it with assent and our ignorance. So if we look at the technological innovation, and think about now again about cognitive function. So this is another hard to reach area, but really critical for population health in its broadest sense. If we think about cognitive function, we can do the same here. These are screenshots actually from one of my trials, and this is about to roll out, but we've just done it in UK Biobank. You can have many cognitive function tests are actually quite simple in principle. They turn out to be quite powerful in practice. So this is a game of pairs. It's snap. So if you get shown two pictures that are the same, you press the space bar, and that's snap. But we record the time it takes you to do it. We also record the number of errors you're taking. Okay, noise concern. This is a decoding problem. So here is the alphabet and the code list. Can you now type in the number that's going on here? Some logic tests. This begins to get a little bit harder. It's not that difficult. This is trail finding. So the challenge here is to put your mouse on 1, go to A, go to 2, go to B, go to 3, go to C, go to 4, go to D, okay? And we'll, again, assess how accurate you are and how quickly you are. And then, because that looks a bit easy, we make it harder. And there's another level above this, in case you're interested. And then you can also ask other questions. So again, logic questions. If Tilda's mother's brother is Tim's sister's father, what relation is Tilda to Tim? Answers on a postcard. And when you track all that stuff, and you start to look at the responses, and again, I'm just giving you some sort of a sanity check by doing it against age, you get some really quite interesting findings. So as an example, processing speed, essentially reaction time, is clearly related to age. So older people, their reaction times are longer. In other words, the reactions are slower than younger people. But you can actually get precision on that, and you can actually now say, if we could actually go and study a different group of people, perhaps people with disease and without disease, and say, if you had this disease, whatever it might be, or you're taking this drug, or you drank 5 pints of alcohol, actually in terms of reaction time, how much older in terms of cognitive health are you in that sort of circumstance? It's quite a useful way of scaling things. And it would be really neat if we could tie that cognitive function assessment on, and we've done that on 140,000 people in 3 months, efficiency, into the imaging. And brain imaging has come on a long way over the last 20 years or so that we can now take, with magnetic resonance, you can take structural pictures. That just means snapshots. This is what you would see if you actually cut the brain in half, only you don't. Diffusion MRI, this is the connectivity. And task functional MRI, if I show you a happy smiley face or I get you to play a game of Snap, which bits of the brain light up in different circumstances. But I want to do that on quite a large number of people. We've just done the pilot of 6,000, and we've just got the funding to scale out to 100,000, doing brain imaging, cardiac MRI, carotid, the main artery imaging, whole body MRI, and DEXA for bone density, so a different issue. But this is large-scale imaging to try and inform the science. And if we actually look at what this might look like, again, a very simple profile. So here is a simple scan of the brain. And what we can find is that at the age at the Imaging Assessment Centre, I think there's on about 3,000 people, that as people got older, the total brain volume got smaller. But this is overall, it's a very crude measure. It turns out you can look at different areas of the brain. You can correlate this with the cognitive function tests and find that some areas of the brain correlate very well with some types of cognitive function and not with others. Some of it would be well known to those who are interested in neuroscience, who know which parts of the brain control which things. Others are quite novel. So we've got this scale of imaging, we can pull these things together. So I think there's big potential for technology in health research in the 21st century. What are we doing locally? Well, we are establishing the Oxford Big Data Institute, which is a partnership, perhaps best demonstrated through the directors. So Gil McVean is the director. He's a professor of statistical genetics. He was in this department of statistics for most of his career. He is a geneticist. I'm a clinician and an epidemiologist. That gives the scientific direction across the whole piece. It spans many departments and many divisions. We picked 4 big themes: genomics and statistical genetics. I haven't talked about that. It's not so much my area. Infectious disease, so surveying malaria outbreaks, dengue outbreaks, and interventions into those. The large-scale clinical trials and cohort studies, which is what I've largely demonstrated today, because it gives, I think, the illustrations. And then, a core theme in informatics, engineering, and analytic methods, with strong collaborations with maths, statistics, computer science, engineering, and indeed others. We're in the process of building a new building. This is what the architects tell me it's going to look like. In reality, it's just a concrete shell at the moment. We're just nearing the topping out ceremony, and it will be open by the end of this year. A few closing remarks, really, on big data. Big data is described as a disruptive technology. I've never quite understood what a disruptive technology is. And when I was at school, those who were disruptive were by and large not helpful. That might be how the previous residents of this 200-person research building feel about big data, a disruptive technology. So we have had to move things, but I think there'll be substantial reward that comes out of this. I think there are challenges. There's organizational challenges. There's going to be a huge blur between what's traditionally thought about as clinical research and what's traditionally thought about as clinical practice. So that's true in genomics. Take a blood sample from some family where there's a rare condition, you take it to the academic laboratory analyze the DNA and all the maths with it, decide that they've identified a new causal gene. That information is of direct relevance back to that patient and that family, as well as advancing science. Absolutely true when you start to look at those imaging, or the cognitive function, or the activity monitoring, where we can now convert activity monitoring into how do we know that people with advanced heart failure are deteriorating or getting better? Well, if you knew how much activity they were doing out in the community, that would help. So you're doing algorithm development and direct clinical care all in one piece. The second is, I think there are real challenges around information governance. This has to be based on trust and purpose. The concepts of ownership and location are really quite outdated. I'm not quite sure where you all think your data are actually residing, but I rather suspect that quite a lot of your data are not residing. You would not be able to point to the place where your data actually sit. It's true of web technologies. It's true of much of cloud computing and many other places. The question, I think, comes down to, if I'm going to allow you to use my data, do I trust you, and what are you going to do with it? Not where does it sit. There are technical and methodological issues. Converting raw data into information, into knowledge, is not really non-trivial, and requires people at each step of this process and people who talk to each other across those processes, which is why the Big Data Institute, I think, will be so helpful. There are resource implications. I think the most tricky of those actually is around personnel. We have to find ways in academia, but actually more generally, to recruit people into this field, to retain people in this field, and to recognize them in this field. People who build really powerful careers in this sort of field will not be producing the sort of publications and the sort of DPhil supervisions and all those things that are standard metrics, either for university recognition or for research assessment exercises and the like. And I think there has to be a substantial rethink about how one rewards the people that are in this field. Sharing data doesn't get you any credit. Publishing data for yourself gets you credit. That's a wonky model. But there are really major new opportunities. And this is just a range of all the different things that one could do. Prognostic and etiological studies. In other words, how do I know who's at risk of having something? How do I know the cause? Discovery science, finding new disease and molecular mechanisms. Experimental and precision medicine. How do I treat the right people with the right drug at the right time? Drug development. Can I actually identify new drugs? Can I establish from genetic markers and population scale data how safe they are? How can I do clinical trials more efficiently? And so on and so forth, all the way through to routine healthcare. So I think big data, the technologies associated with it, are really going to change both our health research outlook and our health practice outlook over the coming years. So I leave you with a slide which I had earlier on. I think this was what big data can do for health research. It can give us scale, it can give us breadth, it can give us length, it can give us depth. And it really, I think, transforms the power to understand disease, develop treatments, and improve health. Thank you very much. Well,
Thank you very much, Martin. We now have time for some Q&A. We have a roving mic. I should say that this is being live webcast and filmed, so if you're uncomfortable with that, just save your question and come up afterwards, perhaps. But perhaps we could have a show of hands and the mic will find its way to you. Any questions? No questions, or was it too thorough? I have a question, if I may, to start. I was very struck by the Facebook data map and the large areas of dark territory, and I just wondered if you might comment, you hinted at it at the end, maybe under infectious disease, but whether the developing world is at risk of being left behind by this revolution.
A very good question. I think if one looks at the mobile phone use across large parts of Africa and the Far East, if anything, it exceeds the mobile phone use per person that we have in the West. I go to China a lot, and the communications revolution in China missed out landlines. By the time that most people needed a phone in the home, we were straight on to mobile technology. So I actually think that there are really good opportunities. Whether it's organised, whether there's the sort of infrastructure behind it to actually be able to use it for health research will vary and will require effort, innovation, be policy issues in it too. Of course, if you just pick up Facebook, there are some sort of cultural issues as well as political issues about who or does or doesn't have Facebook. I think that there are some good examples if you look at, for example, studies of intrauterine growth. In other words, how well do babies grow in the womb, and might they be born prematurely? Well, there are now handheld scanners attached to mobile phones being developed actually in Oxford to collect information which could actually be used in the rural communities of the less privileged world. So I think it's a way of really turning things around. You end up with expertise in one place and the field workers in a different place, and sometimes you don't even need field workers, you go straight to the patients.
Okay, thank you. Please, here at the front.
So were the people that participated in the Biobank project reimbursed for their participation? And if so, was that a substantial cost of the entire project?
It was not a substantial cost because, no, they were not reimbursed. They were reimbursed reasonable travel expenses, but there was no funding for participation. The response rate, which we sent to 9 million people, and the response rate varied between about 5% in some parts of the country, through to 15% in others. I think the highest rate was actually in Bristol, where there's actually quite a long history of this sort of population scale research. No, people volunteered because they wanted to volunteer. When I go to my American colleagues, they actually can't understand that because it's just not the experience there. I think it is a study that at that scale is going to be very hard to replicate elsewhere. In the US, the Precision Medicine Initiative is President Obama launched last year. Their budget for the first year way exceeds the budget for the entire UK Biobank. I think they've got two major disadvantages. One is that it's going to be quite challenging to get people to participate. And the second is that they don't have a healthcare system that is in any sense connected. And so what the strength of Biobank is not when you collect large amounts of data at the beginning, but that you can link all this stuff, including all the technical stuff, through into health outcomes. And you can say, I can take my accelerometer data and say, and relate that to, or at least I can in 10 years' time, what's the 10-year risk of having a heart attack? Well, to do that, you've got to be able to collect the information on heart attack across all the people. We can do it. It's not easy in the UK. There are challenges, they're mostly organisational and governance challenges, but it can be done. I think that's going to be really challenging in the US, where this healthcare system is so fragmented that even the data are fragmented.
Please.
I thought it was an excellent talk, by the way. On your early slides, one of your early slides showed that you showed unequivocally the value of getting really big data sets, and you showed how the error bars go right down really small. But the curious thing, if I remember that slide correctly, was the older age groups, you've got really tight data, but the age group, I think it was up to 59, is still quite wide error bars.
Yeah,
Why is that?
The numbers of events, which is actually what really determines the error bars, is not uniform across those. And so it's often true that in the lower risk people, younger people, women for many diseases, that it's the number of events that determines the size of the error bars. So we need more data. I mean, I think it's, yeah.
Hi, thank you. I was also going to ask something regarding the biobank. I've heard that there's a physical storage facility that's being built for physical samples of patients. Can you talk about that a little bit and how that's going to work, and especially what the scale of the whole project is going to be?
Okay, so I haven't brought the pictures with me, but that was one of the first things that was built for the original Biobank cohorts. It's built and centred in Manchester, so it's a national project. It just happens that Oxford has had quite a lot of leadership in it, and the health informatics has been driven by my team in Oxford. So in Manchester, they have built, the challenge was how do you separate and store these samples? How do you file them away? And how do you find them again when somebody wants to do a study and you want to do it quickly? Because quite often a study will be, I want 5,000 people with diabetes and 10,000 people who don't, out of the 500,000. Then you have to do some work to work out what you mean by who's got diabetes and who hasn't, find those numbers, and then go and look in the filing cabinet and find the samples. So they literally built filing cabinets. There's a warehouse there which is probably as tall as this room. The filing cabinets are probably 3/4 of the height of this room down each side. They're, I think, probably 2 meters deep, and about that far depth each drawer. They're at minus 80, they're liquid nitrogen frozen. There's a tramway down the middle with a robot. You can't freeze a robot at minus 80 because the cables snap. So you have to then freeze the central corridor at minus 20. And then there's a computer that drives all this with an algorithm that says, okay, if you want these samples, then this is the quickest way to get them. Likewise, when they were separating the samples, they built robots in to do all the complicated stuff about how do you actually take off the very thin buffy coat, which is where the DNA is, from all the rest. Something that takes a lab operator some months or years to really perfect. But you can teach a robot how to do it relatively quickly. It turned out the trick was to take pictures from both angles with a set of light, and you can see very nicely the layer, and you put in the probe from the top. And the robot will do it consistently, time after time after time, and doesn't get bored and doesn't go on coffee breaks. So it's those sorts of technologies. Now, what has happened also, because of the success of that, a second similar sort of store has been built in Milton Keynes by the National Institute of Health Research, really as a central location for all the other studies, including some of the existing cohort studies, including existing collections that are sitting in people's smallish labs, but also many of the new collections. And in fact, there's a major round of funding going around at the moment from NIHR, and one of their requirements is that people use that store unless there's a really good reason not to. For many cases, I can't think of a really good reason not to, because that's which gives the backup and the resilience and the expertise and those sort of things for really large numbers. So it's actually quite an interesting case where something developed for one study magnified up for many. And the people who developed it said, well, actually it's not clever technology. Every part in there is a standard part, including the robots. The novel bit is actually working out what the process is, where the errors might occur, what errors you can tolerate, and actually engineering it all to work adequately efficiently. That's where the intellect goes in, not actually in that instance in inventing each piece of technology, which is used in delivery firms all around the world.
You did show at one stage how the genomics people have used their big data to reveal unexpected associations, those SNPs, which are shared by unexpected diseases, for example. Now, have you thought in your centre about doing the same sort of thing for clinical data? So we have clinical so-called syndromes which might not really deserve the name, things which don't really respond to the medication like you thought they might, like mild depression or musculoskeletal pain, all sorts of fuzzy bits of medicine.
Now, is there not a prospect in big data analysis of finding patterns which are currently unexpected in medical diagnosis, in diagnostic labels, basically?
Yeah, well, absolutely. I mean, the first thing today to say is that there isn't a diagnostic schema ontology that actually is robust and evidence-based and reliable. I mean, what I showed there was ICD codes. It works really well on some diseases. Other diseases just don't appear. And if you went to, I think, probably that version or one earlier, HIV didn't appear anywhere because it didn't exist. So the first thing is that the ontologies are not that good. The second thing is that one has to be a little bit careful that with all big data you end up with overfitting. You've got so much that you can model against so much that you'll find patterns that actually are only in your data and not necessarily elsewhere. But I think the places where you're right are that if one can use things like the genetics or the response to a treatment as actually the instrument that identifies that things have some commonality, which you didn't think of. So rheumatoid arthritis and certain forms of inflammatory bowel disease turn out that there are some pathways, genetic and downstream, that are common across those two. And you can take that step forward and then say, well, we already got treatments, the drugs that are used in rheumatoid that influence that pathway. I wonder if they work in inflammatory bowel disease, and lo and behold, they do. Now, those are both inflammatory conditions and not a huge surprise. But drug repurposing is certainly one of the great hopes, using, and particularly I was talking this morning with John Geddes, Professor of Psychiatry, thinking about there really are no new biological mechanisms, his words, not mine, for new psychiatric drugs. But there is an awful lot of other drugs which may well have influence on the brain, which may turn out to be useful in some circumstances. So there's a lot of that can be done. And finally, on drug development, the other piece that's really useful is that if a company were to develop a new treatment that works on a particular pathway, one of the questions they'll be asking themselves really at quite an early stage is, and what else does it do? In particular, what else does it do that's scary, that's a safety problem? Now, the typical with drugs is that where the genetic mutation may only have a small effect on the body, in terms of physiology, the drug will have a big effect. But the genetic effect will have been lifelong. So if you can find a genotype that, if you like, matches or countermatches, it does exactly the opposite of the drug on that pathway, and then study that in a population where that's reasonably common, like in China, there are some mutations which we don't have in the West, but which 15% of people or 20% of people have in China, and say, okay, among people who have this mutation, is there any signal across all the other diseases that either might be, turns out it's a good thing, drug repositioning, or it turns out that it might be a really bad and scary thing, or at least something we should be carefully assessing. So I think there are lots of places where the technology and the healthcare data, even crude healthcare data, could really help with drug development.
We have someone right at the back, Clara, who's been trying to ask a question, then we come forward. I can't hear.
Don't provide an incentive for researchers to work in this collaborative, big data sort of way. I wondered if you could talk a bit more about how you'd like to see research being evaluated in the future.
Well, okay. Yeah, so if I want to complain about the existing, I better have a solution. I'm not sure I have a full solution, but I do think that there's an overemphasis on who is the first author, the last author. If your name begins with is aardvark, I'm sure you're happy with it. But you know, I think there's an issue with that. It's one that there may be physicists in the room, but physics papers typically have thousands of authors, and they're typically alphabetically authored and listed. And somehow they must have solved this problem. You'd think, may not be true. But I think certainly in medicine, this is a relatively new problem. And I know that I've got people in my team who have been working for years on the Biobank data, doing fabulous work, and really have published very little from it. Now, you could argue, well, you should be publishing as you go along, but that's a distraction to achieve something that's not actually often terribly useful, or the number of people who read it is not terribly great, in order to serve one set of masters, when actually the real value is in creating the data set. So I think that more reward for the creation of data, bringing data together, the tools to analyze it, and the sharing of data. And not everybody has to do all of those things. Those things need to be brought into individual recognition as well as institutional recognition. But actually it all comes down to individual recognition, in my view, is that it would be fabulous to have some metric which allows Oxford to float to the top yet again. But when you actually go to talk to an individual researcher, what motivates them? We cannot compete with the major tech industries in terms of funding. My group is reasonably well funded, but there isn't a hope of competing. If Google wants somebody, they'll get them, if it's money that drives it. What we can compete with is that the work is interesting, of, if you like, social value. And what we can also compete with is that actually this is recognised as being important to a major university. There's personal recognition, there's a career out of this sort of work. And I think that's somewhere where Oxford, actually, frankly, any university, needs to be building and using that as a way of recruiting and retaining people, so that people, feel that they're achieving, feel that they're progressing, and feel rewarded and valued, and that's important.
Earlier at the start of your talk when you mentioned that with any big data set there's always a lot of noise. Can you maybe speak a little bit about what sort of safeguards you'd consider very important for avoiding, drawing false relationships between things and being kind of fooled by the noise? There's a long answer to that. I think the short answer is to think carefully about the hypothesis that you're actually testing. Not to just hope that something with a small p-value comes floating out of the data. With this number of data points, something with a small p-value and this number of tests will come floating out of it. Do not be misguided by the p-value. And an element of retest. So if you find it in one set, can you find it in another set? In the clinical world, and actually for much of healthcare, actually it's randomization that takes you from this is a useful association and may well be causal to actually addressing the causal. Now, there are some genetic instruments which arguably can do some of the same things, but for many complex diseases, heart disease, cancer, and so on, where there are multiple factors all contributing, just because two things associated really is not causal. And finally, I'd say as a doctor, when I use a treatment, I have to be mindful not only about I think it's going to cause this benefit, but what harms might it cause? And genetic instruments, in many cases, don't, because they'll give you, if this drug only works through this molecular mechanism, I've got a genetic mapper for that, they'll give you quite a lot of confidence. But there's what I would call the other end of the molecule, which can do all sorts of things to all sorts of other pathways, which you will not get. And if you change from one back end of a molecule to another back end of a molecule, then you may get very different responses and very different profiles. And so actually I think in those circumstances, it's the randomized trials which should really continue to be essential. And just to get back onto that hobby horse, they are frankly unaffordable at the moment. And so the question is, how can a technology make it easier to do the right experiment, not be an excuse to do the wrong experiment?
On the idea of going back to the drug development, a lot of what you've talked about is doing kind of what we're doing at the moment, but better. Is there a chance also to, which simplistically is, I have a disease, so we look for a target, we find something that binds the target, job done. What about maybe serendipitously finding combinations of drugs that act in synergistic and I guess unexpected ways through large cohort studies?
I think one can develop new hypotheses that way. I remain anxious, a bit like my previous question, that these data are not random, clinical data are not random, there's structure in there. So if you take a group of people who are all treated with aspirin and warfarin,
and you compare them with people who are not treated with one or the other or both. You can get some answers, but the reality is that the people who were prescribed aspirin and warfarin and the people who actually took it and continued to take it are quite different to the people who were not prescribed and didn't continue to take it, in ways that are measured, but measured badly. You know, I mean, you have a single measure of blood pressure, you have a single measure of smoking, single measure of weight, all those other things. So there's variability around those, but also in a myriad of ways which are not measured. So again, as a clinician, actually as a patient, you see a patient, you prescribe a treatment, but there's an awful lot of other stuff that you're taking in around the periphery. Whether you should or you shouldn't, and whether it's valuable or not, is a different question. But there's an awful lot of other context that comes into that decision about giving one person, a group of people a drug or not. So I think it's a very valuable way of exploring hypotheses, unless they're really big signals. Probably they're not really big signals, otherwise we'd have already spotted them. Yeah, you don't need trials or even data, really, to know that cardiac defibrillators are a good thing. You need to see one person, and that's convinced you. So these are probably moderate signals, particularly in complex disorders. So I think one has to be somewhat careful in that field, and I think that's an area of caution.
So most hospitals now seem to be moving to electronic patient records and prescribing. Do you foresee a sort of future where all the information from these hospitals are pulled up into big data banks and analysed to look for associations or things that we haven't thought of before?
Yeah,
and if so, is there going to be difficulties interacting with the NHS in that way?
I think you can change all that. Is there going to be to are there? These things are happening now. There are new technologies being used in clinical practice now, some from engineering, for example, for allowing patients to control their own diabetes control during pregnancy much better than they ever were before, producing improvements in the quality of care and the efficiency of care, and in the convenience of care. And those things are happening. Tying those sort of new technologies into the existing hospital clinical record, that's already happening. It's not happening on the scale and as widespread as it needs to, but those steps are already occurring. Combining data even from sort of commercial consumer wearables into the healthcare record is already happening. I think my own view is you have to be quite careful about that because they were commercial grade. What that means is that they had a pretty advert and they look good on your wrist. It doesn't necessarily mean that the heart rate that it says it is actually your heart rate and clinically validated. That's a different question. But these sort of pathways are already happening. In terms of the analysis piece, there are already initiatives to do that. So locally, there's an initiative for particular disease areas to use the clinical data that's in the hospital for particular research questions. Scaling that up across, in particular, in the first instance, the 5 major academic teaching centres in the southeast, so 3 in London, Cambridge and here, so you can aggregate data for a particular disease area across all of those. You don't actually aggregate it. What you do is you send out a distributed query so that the data can stay where they are and you can deal with the governance constraints that way. There's an awful long way to go before this whole thing is sort of just run-of-the-mill and national and so on. And some of that is around finance and some of that is around policy and priorities. And I think it's reasonable. There are places in this country which we know deliver really poor, the hospitals with scandals and so on are delivering really poor care. There are major issues they need to sort out. And whether they're sharing data with each other or with me is really it's important, of course, but it's way down on the priority list. So there's a way to go with that. But yeah, I see bringing together the sort of stuff that was done for Biobank, not all the complicated stuff, but that sort of model, and not doing it in 500,000 people, but doing it in 10 million people, is entirely achievable within the next 5 to 10 years. And actually, I think probably quite likely that people are part of that. Key is going to be building trust with patients and the public. Why are we doing all this stuff? So it comes back to that question about why did those 500,000 people turn up and do these things when they weren't getting paid for it? It was because they felt it was worthwhile. It was because they thought they were giving something back. It was because they trusted us to do the right things and with their information, both from just looking after it, but also making sure it goes to a useful purpose. And trying to expand on that across a more sort of routine national scale is going to be really important. There is in some communities, I think in my own view, an over-reliance on consent. if one has to, if to do any data sharing, as an example, one always has to have individual consent. One needs to be really careful. There are substantial sections of the community who only engage with the healthcare system when they're really needed. Probably quite a few in this room who really are going to avoid the healthcare system completely until they have an accident on their bike, until they have a stroke or whatever else it might be. Then suddenly they're patients, they're really interested, but just now may well not be. There are also substantial sections of the community where health is not a priority, the education standards are lower, English is not a first language. There's a whole load of other issues. And I think if one's not careful and says, unless you've got consent, you've got to do these things, this is where the trust and the purpose comes into it, then actually one could end up alienating the most needy and ending up in what I would describe as the Californian paradox, which is in California, you have the worried well and substantial numbers of them who are really engaged and wear every device. They're not the people who need every device and every piece of help. It's actually the people, if you find someone without an armful of watches, that's the person who's probably got the medical issues. So I think there is an issue about access and parity, if you like, of care that needs to be considered alongside the reasonable claims of autonomy and so on.
Thank you. You just touched on the topic of consent again, and you also talked about consent forms before. In 2005, when you set up when the Biobank project was running, and you very impressively demonstrated that already back then you were using electronic consent forms, and then you also had those handy screenshots of the iPhone consent forms. Why is it that large-scale projects like the 100,000 genome project and other of the sort don't use forms like that but still rely on paper?
I think that there's a lack of awareness of what's really possible. That's one element of it. And of what's really acceptable. Demonstrate that things are acceptable. I think that sometimes researchers are so keen to get on with the research that they feel that, and to get the research started, that dealing with the ethics committee or whoever's got to approve in the most expedient fashion is viewed rather strongly or given greater weight than necessarily what could be a more lengthy discussion with them about what is the optimum fashion. There are many, and the other thing is that the technologies, yes, they're available, but there are still questions of implementation. There isn't really an off-the-shelf consent mechanism that you can just say, you can buy off-the-shelf paper, you can't buy an off-the-shelf electronic consent mechanism. I'm sure you can buy screenshots. But that really has thought about all the issues. And the issues are complex. They're not only about when you consent in the first place, they are also, and how do you know it's the right person who signed the consent form and not their neighbour or whatever else. There are also issues about then how do you act on it. Now, one of the wonderful things we saw in Biobank was actually because we had the data directly into the database, we could always act on it. Every downstream system, whether it's the lab system or the flagging system up to clinical records or whatever else, had to obey it because it was there in the data, not on some piece of paper. But that still needs to be built through. And then what happens when somebody changes their mind? And naively, people think, well, people either consent to take part or they then withdraw their consent. In reality, what happens is that people, to get into a particular study, you typically have to consent to a package. You say, oh, I've read all that stuff, and yeah, that sounds fantastic, and I sign here, and I'm agreed. When it comes to withdrawing, people have various levels. I don't want to take your tablets anymore. I don't want to come to clinic anymore. I don't want you to phone me anymore. I don't want you to contact my doctor about me. I don't want you to contact national records about me. I don't want you to use my samples anymore. I don't want you to have anything to do with me at all. And those are complex, not only in terms of how you manage it and explain it to patients and the people recording the changes of consent, but also in how you control the downstream systems. There's no point recording these options if they're not actually going to do anything with them. Now, my own view, again, is that the electronics, for want of a better word, can actually do all that for you. But it's got to be quite carefully thought through, and we haven't got far enough forward on that. My final point on this is that, of course, much of what's done in consent is driven by regulators in the drug regulators. And big pharma is always scared. They have an additional scare, which is that somehow the regulators will have a reason, not to do with the results of the study, but to reject their application. So they spent $500 million on this study. They really don't want someone to come back and say, oh, your consent wasn't valid. And again, I think that's misplaced. But that then spills over into how a lot of us behave all the time. I said that was my final piece. My other piece would be, if you go to the clinical world, if I want somebody to have an operation or an investigation in the hospital, it's a paper form in triplicate that we fill in. But sadly, we're still copying that for the research setting. I think we can do much better, both in the clinical world and the research world. And I actually think the research world can get it right first, and the clinical world can copy after. The clinical world is not great at innovation.
How do you exploit with doctors the use of that data and the spread of allocation to specific treatments using that? So you talked about the fact that there's an 85% opportunity to actually do something much more scientific. So when presented with a patient, how do you intervene with that scientist the person who believes themselves to be a scientist and say, if you want to be truly scientific here, don't just prescribe your favourite treatment in this instance, but I want to intervene and I want to give the random a treatment in this instance so that we can establish what the scientific response to that is.
Well, I think there are several barriers. One is an area of education. That actually most of what we do is not truly founded on the best evidence. One is an area of professional pride. And that's not just on behalf of the doctor, it's also sort of on behalf of the patient too. If I gave you a choice of going to see a surgeon who was certain or a surgeon who was uncertain about whether to do an operation or not, I think we'd all go to somebody who knew their mind, and they won't express it to you as, I know what's going on, but somebody who said, I haven't got a clue what's going on, we're just going to randomise, might cause alarm. And that, I think, is a tension I've caricatured, but it's a tension that does arise in that one-to-one clinical context. Another issue is that one finds in large areas of medicine that there is global uncertainty, but not local uncertainty. So one group of surgeons will do this operation, another group of surgeons will do that operation. Each will be absolutely certain that that is the right operation to do, and will be able to recite all the evidence that goes behind it, the background, if you like, knowledge that goes behind it. But actually, globally, it may not be clear that one operation is better than the other. And so there are some challenges there. I think the other challenges come from the regulators or from the regulations of one sort or another. If I want to prescribe half my patients 3 days of antibiotics and the other half of my patients 5 days of antibiotics, and frankly there is no evidence to tell me that for inner ear infection or middle ear infection one is better than the other. If I want to do that on an alternating basis, you come into the clinic 3 days, you come into the clinic 5 days and so on, that's fine. If I want to do that in the context of a research setting, so I want to count all that up at the end and say 3 days turned out to be better than 5 days, I now need consent, I need ethics approval, I need a whole load of governance approval, there's a whole bunch of regulation. So it's easier to act randomly or indiscriminately and learn nothing than it is to randomise and learn something. And that's really unfortunate. And this is a point that's been around for 50 years. There were Austin Bradford Hill, who ran the first clinical trial of TB therapy in 1948 or so. He gave a lecture, he was a statistician, MRC statistician, gave a lecture at the British Medical Association in 1963. As old papers go, for my world, 1963 is quite an elderly paper for modern medicine. It is a fascinating read because it talks about why would you need more consent to do research than you would to do clinical practice. Why would you do you need more approval, more difficulty to do a controlled experiment than to do an uncontrolled one? So I think there's an awful lot in there, and this has been embodied into regulations such as the ICH good clinical practice, which have made it harder and harder, and that's what's driving up the costs. So there are, if you like to answer your question, there's some social issues about interactions between individual patients and their doctors and vice versa. I think there's some awareness issues about doctors accepting that we don't always know for certain that this is the right or wrong thing to do. And then I think there are some structural issues around the regulation and the operation to actually gather the information together.
I think we're going to have to stop there. We're running out of time. Before we thank Martin, I just wanted to draw your attention to a couple of other forthcoming events here. This, as I said at the beginning, is the first of a weekly seminar series this term on technology. Next week, again at 5 o'clock, we have Nanotechnology, the Big Picture, and that's Dr. Eric Drexler, who is a Senior Visiting Fellow at the Future of Humanity Institute, and Dr. Sonia Trigueros, who is part of the Oxford Martin Nanotechnology Programme. They'll both be speaking on that. And the following week on Mind Machines, the Promise and Problems of Cognitive Enhancement Devices. And that's Professor Roy Cohen-Kadosh, who is Professor of Cognitive Neuroscience, and Dr. Hannah Maslin, who is based here at the Oxford Martin Programme on Mind and Machine. There are lots of other events after that, and I'll leave you to consult the website, but those are the two that are forthcoming. And what also may be of interest, because it's coming at the technology issue from a slightly different angle, we have the well-known economist Diane Coyle coming to speak on February the 2nd, here again at 5 p.m. on, that's Tuesday the 2nd of February. And she's just written a book, GDP, A Short But Affectionate History, and she'll be looking at how GDP is being digitally disrupted and therefore inappropriate for the 21st century economy. And so she'll be signing books and giving a talk on that. So please, there are many other events. Keep looking at our website, but we'll close with thanking Martin once more. Thank you very much.